I'm Patti O'Brien. I'm going to be talking about survivorship care in the primary care setting. I'm particularly interested in this because I work in oncology rehab, and we try to get folks ready to head back to you. I'm trained to be a primary care provider. That's what I used to do, but now I work with Oncology Rehab, and I became interested in that because I've been treated for cancer myself. So hopefully you got handouts, and these are our learning objectives. The idea is for you to feel comfortable providing comprehensive care for the unique physical and emotional needs of survivors in your practice. Know how to screen for the late effects of cancer. That's a really important issue we're going to talk a lot about. The good news is we get lots of cures, but at a cost. And so how do we look for the late effects of cancer treatment, and what are the things we need to follow up with in those patients? When do we need to send them for specialty intervention and screening, and how do we educate our patients about these late effects? And I'm just going to close this door. And I have no conflicts of interest. So why is this topic important? This topic is very important because we're getting a constantly increasing population of survivors out there. So in Vermont, we have over 40,000 survivors who've been treated for cancer who are going to be coming into you for their primary care. So these numbers are going to just keep rising, and you'll have over 8,000 survivors who've been treated for breast cancer. But we're going to talk about all cancer survivors. So what we have to figure out is how do we take those patients from hematology and oncology and move them back into primary care so that you're treating their whole body preventatively and comprehensively. So who are the typical cancer survivors you're going to see in your practice? Well, the characteristics of the survivor is the breast cancer population is always going to be a big group of them. This is a women's conference, so we're not as concerned about prostate, but they're out there. They're about 17% and about 11% colorectal. The good news is 64% of adult survivors are expected to live at least 5 years after their diagnosis. Most people diagnosed with cancer are going to be over age 65, but this is what I want you to focus on. 50% of them are going to have late treatment-related side effects. So and those are the things that you need to be screening for. So there's lots of shared care challenges that are going to be a part of what we all have to deal with. So there's no clear definition as to when people should be moved from specialty care back to primary care. There's a real lack of infrastructure. Our medical records don't talk to each other. On one hand, we're always worried about liability, but the other hand, we're told to keep costs down. So how do we make sure people don't fall through cracks? The research clearly shows that primary care docs are much better at taking care of chronic diseases and have better outcomes with lower mortality and hospital rates for these chronic diseases. But we need our hematologists and oncologists to help with these very specialized areas of knowledge. So how do we combine them? And the survivor document is the thing I really want all of you to be very comfortable saying, I want a survivor document for my patients. And we'll talk about how you get that. So a survivor document is a summary of the care. So it's after the person has finished their primary cancer treatment of their surgery, their radiation, everything. It should outline what they got for care. It should tell you what type of screening is needed for possible recurrent care. It should outline the treatment morbidities. So what were the long-term potential complications of that care that was given. If there was genetic testing done, it should tell you what the genetic test results were and the implication of those results. And it should also suggest risk modification strategies to decrease their risk for recurrence. So in our clinic, Penny Gibson is the one who is our survivor specialist, and she's the one who makes these survivor documents. And patients can schedule an appointment with her, and she meets with them and creates these documents. And a document should go to the patient themselves and to the primary care provider. So let's start talking about the side effects of cancer care. Most of us think of the typical side effects. Oh, the patient's bald, they have a white blood cell count, their skin may have some changes from radiation, and we think about those going away in 6 to 12 months. But those aren't really the ones that I'm concerned about. What I'm much more concerned about are the irreversible, the indolent, and sometimes progressive changes that the patient may not really even know that they have, because they were so worried about, oh my God, I've got cancer, oh my God, I need a cure, that they didn't really listen to the potential long-term side effects of the treatment that they got. A major one that people don't realize is that they may be at increase for a second malignancy, which may require specialized screening and education and decreasing their risk factors for this. An example of that might be the patient who was treated for Hodgkin's lymphoma, got mantle radiation, but now they're at increased risk for breast cancer. And so you really want to follow that patient who's been cured of their primary cancer, but they're now at increased risk for a second cancer. Or the lady who had breast cancer, who got radiation, but now her lung is at increased risk for lung cancer. So a lot of patients kind of didn't hear that when they were told that, but they don't want, for reasons which I fully understand, they're pretty angry when they now have a side effect of their cancer and they're years out and they're going, oh man. And so I think sometimes the primary care providers are the ones that are going to be the ones having those discussions with people about the long-term side effects. I treat lymphedema. That's one of the major things that I do along with Oncology Rehab. And people will often be really angry when they get their lymphedema and like, how did this happen to me? Well, you had an axillary dissection, you got axillary radiation. And they're like, well, nobody told me I'd get lymphedema. And I'm like, I bet they did. I really bet they did tell you that you might. And I'll sometimes literally go back to the chart and show people that they signed an informed consent. But what you hear kind of, you don't process everything at the time of your cancer. And that's okay. You needed your cure. So let's talk about why you might have sent somebody into the oncology world and they seemed kind of young and strong, and then when you got them back, they seemed old and fragile. And what did we do to them? Did we beat them up? And yeah, we did beat them up. We gave them cancer, a cancer treatment to try to cure that cancer. And along the way, there were a lot of side effects from that cancer. And they had this collateral damage to other parts of their body. So hopefully they got a cure, but they came out the other end older appearing and more fragile. So let's talk about how do we get these patients back into shape and why did they become older and more fragile? Well, a lot of times we treat solid tumors with surgery, and surgery leaves you with a lot of different problems depending upon what the primary cancer was. So if you had one kidney, we're going to take it out, but your other kidney is going to have to work harder. If you had a GI or a colon-related thing, there's going to be surgical interruption. We may create incontinence. We may change your sexual function. You may be left with lymphedema and cellulitis, lots of scar tissue. You may be at increased risk for small bowel obstructions. There's a lot of things that happen because of the surgery. And so you may be left with a patient who has some chronic pain and some chronic body image changes because a solid tumor needed to be removed. Chemotherapy, we all think, oh yeah, chemotherapy, it's systemic. It affects all parts of your body. But are we really thinking about the long-term morbidity of chemotherapy? Not just the going bald. The going bald's easy to fix. Just give hair time. It comes back. But it's those later complications that I want to talk about, the cardiovascular complications. And everybody's going to be unique because everybody got a different dose and schedule, and they got their cancer at a different age, so their heart was, had different susceptibilities. We suppress a lot of ovaries with cancer care. We create infertility, changes in libido. And everybody sort of expects, oh, I'm going into chemotherapy. This isn't going to be fun, but I can put my head down. I can do it. What they may not realize, though, is when the drugs stop, some of the symptoms may last, and people aren't necessarily expecting that. The same with radiation. Radiation saves a lot of lives, but there's a lot of innocent bystanders that get hit. That radiation beam is not perfect. So the heart can be affected in any part of the heart can be affected. You can hit the valves can become calcified, the myocardium, you can lose muscle tissue, pericardial tissue can be damaged, coronary artery, electrical changes. So, and if you give radiation at the same time you give chemo, which particularly for head and neck cancers is fairly standard, you increase the potential for side effects. And the latency of radiation can be 10 to 20 years. The incidence is 10 to 30%, and it really, 10 to 30%, that's a huge variation. But it depends on what you're going to call a latent side effect. So a lot of it is definitions. But we're going to really spend some time talking about the coronary artery disease issues. And anything that's in that field of radiation is at increased risk for developing skin cancer. And particularly your head and neck cancer patients, the thyroid is often hit and the carotids are often hit. So they're a group that we really need to think about. So we often, think, oh yeah, acute radiation changes. Yep, the skin's burned. There may be some open ulcerations. They may have these changes, but wherever you see these changes, you need to think about melanoma or other types of skin cancer later. You also have to think of what was under that skin. Remember, the beam goes in one side, comes out the other side. And everything in between that got hit by that beam can potentially have changes. So here's your standard radiation treatment. There's your breast. You're trying to get the beam to go through. You're going to avoid the heart as much as you can. And you're going to, the newer patients, they'll try to time the radiation beam with the breath holding and try to get the heart out of there. But you're going to have lots of patients who that wasn't an option where they got treated. And they weren't able to keep the heart totally out of the field. So just remember, everything that's in that beam potentially was an innocent bystander and got fibrosed. Acute radiation issues will resolve, but wherever that radiation beam was, you can get some changes afterwards. So here's a CAT scan of the person during radiation. Here's how everything changed afterwards. And so you've got some pulmonary fibrosis, the whole mediastinum is getting moved over. And so the shape of how those lungs are working is going to change, drainage is going to change, and you may have increased lung toxicity. So let's talk about the lung. fibrosis can be related not only to radiation therapy, but also to the drugs itself. So bleomycin being a drug which we know can cause radiation fibrosis. You've got then surgical scars that can add on to it, and so people may be left with different pulmonary function. If their lungs aren't draining well, they may be getting recurrent infections. If they get recurrent infections, they may get more lung damage. So we really need to look at their lungs holistically. And some of these patients are also going to be immunocompromised. We've given them a lot of steroids, so we need to be thinking about fungal infections in these folks, that atypical infection. So let's go from their lungs to their bones. Again, you may have sent the person to oncology as a healthy-looking person, and they come back looking a little more frail. Why did they get frail? Well, we've done a lot of things to them to increase their risk for osteoporosis. So how do we take care of their bones? They're at increased risk for osteoporosis because of the steroids that they were given. Steroids really, really help people tolerate chemotherapy, but they have a lot of side effects. Your patients may have had premature menopause from the drugs. They may have had radiation therapy, all of which is going to affect their bones. But this is something we really have to take into consideration. We may have turned our patients into couch potatoes, and they're not active. They have less weight-bearing exercise, so their bones aren't going to be as strong. They may have lytic lesions from their hematologic disease, so their multiple myeloma, or they may have metastatic tumors. So you're going to need to follow people's bone density. You may need to look at bone scans depending upon where they're at in terms of their survivorship. Think about drugs and lifestyle changes. Think about having them do weighted exercise. They may need special help with diets and supplements. So there's lots you can do to try to reverse that bone damage. And as somebody who works in oncology rehab, think about getting them into a structured oncology rehab program. Chemo brain. Chemo brain is a term that is used loosely. 20 years ago, chemo brain wasn't a term that was used a lot, but now it's used loosely and means different things to different people. Basically, it's neurocognitive changes, but it really shouldn't be called chemo brain because it's not just chemotherapy that does it. The tumor itself can cause it, the steroids we give people, the radiation. So there's a lot of different things that can cause people to have different cognitive alterations. For some people, this can be very severe and life-altering, and they may not be able to go back to their previous employment. Most of the time, it's going to be a short-term problem, and people are going to get back to their previous level of functioning within 2 years. Fatigue is typically going to make it worse. And for some people, there may be genetic predispositions to being sensitive to the chemo drugs. There's some data that says certain genetic groups may be at increased risk for Alzheimer's. So when our patients complain about this, we really need to take their complaints very seriously and be sure that we're getting them appropriate intervention. But most patients, it's going to be fairly mild, but we need to think about the fact that people are dealing with depression and fatigue, and that can all get rolled in together. This is a slide that I just think really helps me understand what chemo brain feels like. So this is an fMRI of people you're looking at their working memory. So this is a woman who was treated for breast cancer, and this was her healthy twin sister. And this right here, they're doing very simple math projects. The math is getting a little more difficult. The math is getting more difficult. What's interesting is that both sisters are answering the math questions correctly. So if you're just looking at them from the outside, the two sisters continue to look identical, they're scoring identical, but they're subjectively reporting very different function. The one who had the chemo says, I'm tired by the time I get done at the end of the day. This one's feeling well. Well, think about why. This one who got the chemo, look at how much of her brain is working to do the same math memory problem that her sister is doing. The math gets a little more difficult, more of her brain is turning on. This one's just beginning to work at it. A longer memory problem, and she's really working hard. Her sister's barely working. So if you think about comparing the brain to a muscle, how much muscle do you need? Of course the one who got the chemotherapy is really tired by the end of the day because her brain's worked harder. So just because your patient appears normal to you, it doesn't mean that they're not having some issues. So getting them into the intervention will help. And things that will help will be speech and language consults, may help with some diagnostic studies, occupational therapy, may help with activities of daily living, helping them plan. Treating depression and anxiety will always help. Formal neurocognitive testing may be helpful, particularly if they need a disability application, and some people will. So we really want to listen to people when they say they're having problems. So if we can hit the central nervous system, we can also hit the peripheral nervous system. Chemotherapy can cause peripheral neuropathy, and it is sometimes a dose-limiting effect. Platinum drugs and taxanes are the two classes of drugs that most commonly cause this. Different things you can try for these patients. Gabapentin may help. Acupuncture, be complex, but most of the time this will get better with time. Physical therapy may help because these people may be at increased risk for falls. Like a diabetic patient, you want to try to prevent injury, so trying to, protect the foot will be helpful and prevent skin problems. Lymphedema is the thing that I often treat, and lymphedema can be we often think of it as a swollen leg after groin surgery or a swollen arm after axillary surgery. But we can see it in any part of the body. And so particularly, we're now seeing a lot of head and neck cancer patients. And it's important to realize that it can happen at any time, not just at the time of the therapy. It can happen years later after other parts of the lymphatic system wear out. If a patient comes into you with new onset lymphedema, they're in your practice, you're seeing them 5-10 years later, you always want to think about, is this recurrent tumor? But most of the time, it's not going to be. So most of the time, when I see somebody who didn't develop lymphedema initially, but 10, 15 years later, it's a new onset lymphedema, the biggest cause that I see is weight gain. They've just slowly gained weight. They're wearing out their lymphatic system. But you also have to think about infection, burns, trauma, other things that are going on. But you do have to rule out recurrence. So these are just some typical pictures of lymphedema in the leg. This particular lady had a cabbage, and she had her veins taken from that leg, and then she developed lymphedema. Typical arm, but this is what we're seeing a lot more of now, are the head and neck cancer patients and developing the lymphedema in the neck. With our GYN patients, we can see labial edema and genital edema, and that can be very painful and really needs some special attention. This is the thing we worry about, is patients developing cellulitis or infections. And with, cell phones now, people email me pictures. It's great. I mean, it's just wonderful that they'll send a picture and we can get them going on antibiotics quickly. So I try to teach people to recognize what an infection is. Many of them have Keflex or antibiotics at home. I keep mine in my suitcase because I only get infections if I go away. That's just how it works. Prevention is key. So trying to, prevent trauma, wear gloves. I see a lot of patients who have skin issues, something chronic like psoriasis. And psoriasis and lymphedema are not a good combination because they just keep making, the psoriasis keeps giving you infections, which makes your lymphedema worse. So you want to treat the whole person, and being aggressive about that skin care is going to be important. I see more breast lymphedema now than I see other types of lymphedema because for so many breast cancer patients, they can get a lumpectomy and radiation therapy. But now they're left with a breast that can be very large and painful. So compression, special bras will help. Get them out of underwire bras, get them learning to do self-massage, and PT and MLD will usually help with that. So at our lymphedema clinic, you're seen by a physical therapist and a physician at the same time. You're taught to do the manual lymphatic drainage. Usually insurance will cover that, trying to get compression to the area. And there's a variety of different tools that you can use, and there's lots of information out in the exhibit hall on that. Compression really needs to fit well, or it can do more harm than it does good. It's not always covered by insurance. All of these supplies have a limited lifespan and need renewal. So your patient that comes into you who's wearing a 5-year-old sleeve, it isn't working anymore. So, those have a limited lifespan, and so get people to keep up on their tools. Sometimes we need lymphedema pumps. Those are usually, take some time to get a prescription for those, but usually we don't need them, but sometimes we do. And usually insurance will cover at least part of it. Alcohol and cancer is a very important lifestyle. We know that alcohol can be linked to many different types of cancer on a primary basis, but it can also increase your risk for recurrent cancer. So all of your patients need to be concerned about alcohol, but particularly your cancer patients. And this stopped forwarding. Any technical help here? I don't know what I did, but I hit some button. Okay. All right. So alcohol and cancer. So I got it. I fixed it. I don't know what I caused, but whatever. I figured it out. So think about alcohol in your cancer survivors. Cancer survivors are going to be at increased risk for alcohol abuse because they've got lots of fears about, recurrence, depression, anxiety. They may, not be successful in cutting back on their alcohol use until all these other issues are addressed. And our patients who've seen a lot of drugs may not be able to process it. Their livers may function differently. So really be sure to talk to your patients about their alcohol use. I want to spend some time talking about cardiac disease. And this is something we really look at in oncology rehab because they come into their cancer diagnosis with their own risk factors. They may have been obese and smoking and hyperlipidemia and diabetes before cancer, But then we did surgery, radiation, systemic things, and we added to their risk factors for heart disease. And then we got them sitting around. They were getting older anyway. Maybe we gave them hypertension from their drugs. And now they're at increased risk for heart disease. So that's an issue I want to talk about. So here's just some 7 years after breast cancer treatment, people are going to show impaired fitness. So here's the control population. If you just got surgery, 7 years later, your fitness is probably going to be pretty good. If you had surgery in just one modality of intervention, your fitness hasn't dropped much. But most of the time, we do multimodality intervention. Most people are getting some kind of drug, some radiation, some surgery, and 7 years later, they're going to have impaired fitness. And it's not just our breast cancer patients, it's our GYN cancer patients. So control and ovarian cancer. 10 years later, our ovarian patients are significantly less fit. Our endometrial cancer patients are significantly less fit. And our cervical patients are not hit as badly, but they're hit. So fitness is an important part of trying to keep people healthy. So why did that fitness drop? So let's talk about the drugs. Adriamycin or doxorubicin, the epirubicin family, is used to treat many different solid tumors and hematologic malignancies. So lots of our patients have seen this class of drug. It's a dose-dependent progressive decrease in left ventricular function. So these people develop cardiomyopathy because myocytes drop out. That's why when we're giving these drugs, we test people's ejection fraction and monitor it during chemotherapy, and we may stop chemotherapy if their injection fractions have dropped too much. The first manifestation is going to be diastolic dysfunction, and so you really want to be keeping track of people's heart. If they develop congestive heart failure, you want early identification of that because you can treat that and improve their left ventricular ejection fraction. The people at highest risk are going to be the pediatric cancer patients who got these drugs at a young age, or our older patients who got it at an older age. The group you really want to watch are your patients who got treated as kids and now are pregnant, can develop sudden onset congestive heart failure during their pregnancy. So they thought their cancer was behind them. They may have gotten their drugs when they were really young. They don't even really remember it. But then they get pregnant and can get into very rapid cardiac problems. So you really want to watch them. This is just showing that our older patients are the ones that are most apt to have the heart failure. So those people who are over 60 at the time that they got the drug are at greatest risk. It's not just adriamycin. Herceptin or trastuzumab and our biologic agents, the HER2/neu agents, can also cause cardiac problems. That's usually reversible, but about 1% of breast cancer patients who are treated with Herceptin may have some long-term changes in their ejection fraction. The anti-angiogenic agents, this whole class of drugs, can cause quite significant hypertension as you're giving it to them. It's dose-dependent and duration-dependent upon the drug. But because you're causing such severe hypertension, you can get acute congestive heart failure, acute coronary syndromes, and these can cause later complications. The vasoconstriction can be related to late side effects. So as these people are getting those drugs, their blood pressure, they're trying to treat it as aggressively as they can, but there can be long-term side effects. The platinum agents, the cisplatin, oxyplatin, carboplatin, that whole group can cause increased risk of premature atherosclerosis due to endothelial damage. So just think about all these drugs which we give, and we put that on top of the patient who's already obese, already diabetic, already hypertensive, and hyperlipidemic. And you're really getting a complex picture of cardiac risk factors. So a moment of levity here. He's complaining of chest pain, shortness of breath, cramps, and dizziness. Do you sell earplugs? We have to really, really listen to our patients when they say they're having chest pain or feeling short of breath. We've got to think about that long-term survivor, and they may be much more apt to have cardiac disease than recurrent cancer. And unfortunately, I think cancer kind of gets in people's brains, and we don't think enough about their hearts. We also need to think about their sex. So intimacy and sex after cancer are very important topics that we are not very good about talking with them about when they're in cancer care because they're so darn tired. We don't expect them to be terribly sexually active while they're in chemotherapy. They're anemic, they're exhausted, they may be dealing with acute depression and emotional exhaustion, but we need to be sure their sex lives are taking off again. Sometimes their partners may have unrealistic fears of them because they're, oh, you're radioactive, I can't get near you. No. They're not radioactive. Occasionally they are radioactive. Sometimes we do put seeds in people, but that's very rare now. There are some drugs that when people are on, we ask them not to be sexually active, but most of the time you can be totally active. You just may be exhausted. So talk to people about their fears about sex. A lot of times sex isn't working, though, because old sex doesn't work, and we need to talk about new types of sex. So women who went into early menopause probably are going to need lots of lubrication. They may have a lot of pain, so you can get lidocaine creams, which will decrease some of that. People who had colostomies or have ostomy bags may not be able to use the same positions that they did. People who had a lot of radiation therapy, being on the bottom, sex may not work like that anymore, it may hurt. So you really need to encourage people to be creative. Sex therapy may be helpful, pharmacies may come up with things, but I really just encourage people to think about it and talk through what their issues are, and literally schedule time to try, because they may have tried and sex didn't work, but you got to get them to try again. So exercise improves survival. And so let's talk about if you can get your breast cancer patients to really exercise, they have a 30% lower risk of dying from their cancer. Colorectal cancer, 50%, prostate cancer, 30%, brain tumors. So exercise is extremely important, and that's one of the reasons we've come up with our oncology wellness program, is that we try to get people into steps to wellness. It's a 12-week structured exercise program. If we need to, we do a treadmill test before they come into the program to make sure that they're safe to exercise. And we know that the breast cancer population is the one that's had the most research done. But if you can get people exercising, they're going to have a longer disease-free survival, and they're going to have an overall longer survival, so that everything is going to improve. Now, so what are the mechanisms as to how exercise makes you live longer? We don't have the answer for that yet, but we have a lot of theories. When you exercise, you're decreasing inflammation, you're improving insulin, insulin sensitivity, you may be decreasing circulating estrogens. So these are theories as to how it's working, but the absolute answer is not known. Muscle is a secretory organ, and when you're using your muscles, you're changing a lot of different factors there. So there's this whole cascade of events that happen when you exercise. So we don't know which of these things, or maybe it's a combination of all of these things, but we know that exercise will improve your overall outcome. We know that fat increases your risk for recurrent cancer. So if you can help people lose weight, you're going to keep them healthier. But, you know, we can't keep our non-cancer patients to have good weight control. And so now we've got to really figure out how to help our cancer patients. And again, we don't know which of these things it is. Is it the insulin regulation? You know, is it, you know, IL-2? We don't know which of these things is doing it. But again, we do know that there is a relationship between trying to help people lose weight and their overall wellness. So now, how do we take all of this information that we've talked about and be sure that we're having the patient that comes into you get all of the tests that they need? So you've got to do a mental health screen. Your patients may be at increased risk for depression, fear, anxiety. They had cancer. They've got those things. You got to do all your routine blood work. You got to make sure that they're getting their colonoscopy, their mammogram, their bone density. So everything that you do for your annual exams. But you got to talk to them more about their weight and their blood pressure. You got to talk to them more about their cardiac risk factors and try to really aggressively keep that blood pressure under control. Aggressively be sure you're keeping up on their EKGs, and probably doing more echoes and ETTs than you would in your other patient. Aggressive obesity control and talking to people about their lifestyle. So here's sort of a laundry list of concerns. So your head and neck cancer patients, again, because of that head and neck radiation, they may have a lot of neck musculoskeletal things. They may have more carotid disease, thyroid disease. People who got exposed to, people who had one malignancy may be at increased risk for a second malignancy, so they may need more genetic screening. People who got chemotherapy, you've got to look for myelodysplastic syndromes from their chemotherapy, so that CBC with a diff is going to be really important, looking for hematologic problems. The bottom line is every single cancer survivor is going to have a very specific set of needs. And the only way, well, for most of us, the only way you're really going to keep track of that is to get a survivor document. So have oncology give you all of this for that cancer patient. What dose drugs did they get? What's their risk for heart disease? So let's just quickly go through a case study. So this is a 56-year-old woman. She has a history of early stage breast cancer. She's no longer seeing her surgeon who did a lumpectomy anymore. She's done there, but she's burnt out with the oncology department. She's sick of them, but she did get adriamycin, Cytoxan, and Taxol. She had a lumpectomy, so she got radiation therapy. And she must be tied into them somehow because she's still getting an aromatase inhibitor. And this would be really common. This is a very common scenario. And she may present to you with some upper extremity problems related to her surgery and her radiation therapy. She may be depressed, she may be obese, hypertensive, cholesterol. She's so burnt out, she didn't, you know, she got too many breast exams, so she didn't bother to get the other end examined. So she hasn't gotten a pap smear in years. She never got a colonoscopy, no exercise plan. These are actually pretty typical patients out there. And she may not really realize she's at risk for cardiomyopathy, coronary artery disease. She's not going to be happy to hear that she's at increased risk for these issues. So what do you do and why? So because of her chemotherapy and her aromatase inhibitors, she's going to be at increased risk for bone loss. And, you know, getting a DEXA scan, that's pretty easy. You can start her off there, talk to her about weight-bearing exercise, get her on some calcium. She may need some vitamin D. Then you got to talk to her about how her AIs may have altered her lipids, and talk to her about her lipid profile. The AI might have also given her a lot of joint pain. So you got to get her into an exercise program and talk with her about why she's not exercising if she's not. Then you got to get into the big issues of what are your cardiac risk factors, and do we need to do a treadmill test or an echo, and get into that weight reduction, and that she may not be happy about this. Got to look at her skin, and any place that got radiated, you got to be sure there's no secondary skin changes there. She's probably going to avoid the pap smear and the colonoscopy, but you got to get those done. And consider some baseline PFTs because she got the radiation therapy. That routine blood work has got to be followed up on because she's got increased risk for these being abnormal. For some reason she hasn't gotten into physical therapy, but you may need to get her into physical therapy, into Onc Rehab, and learn about the lymphedema that she is at risk for. So a lot of people got through that cancer treatment, but they may have some other problems. Again, Penny Gibson is the person who creates these survivor documents. And if you have a patient in your practice who you feel needs that, then get them in. And these are wonderful CME things that are very good that I wanted to just put there because I've tried to go through a lot of stuff quickly, but these are good resources. So now we have time for questions. Questions? Sure, there's some questions. Yeah.
Does Penny do these? Does she happen to do them for patients that don't go through?
Absolutely, yes. So you can get a survivor document from where you went through therapy, and they are mandated, and all places are setting up survivor, the ability to create a survivor document. But Penny can also do them for you, anyone referred to her, but she'll need all of your treatment records so that she can figure out what was the total dose you got, what was the radiation field, yada, yada, yada. So you need a lot of medical records to come up with this. That's why it's best done right at the end of your treatment, because then everything's in one place. So most people should be getting them now at the end of their treatment, but there's a lot of catch-up to be done.
Consider elective surgery in a liver with lymphedema contraindicated all the time?
No.
Or is there a way to be planful?
Absolutely a way to be planful and manage it. We should all, just because you got treated for cancer doesn't mean you go live your life. Or just because you got lymphedema doesn't mean you don't go out and have a life. I mean, I have lymphedema, and I do any sport I want to do. I rock climb, I ski, and occasionally I screw up big time. And last year, I was so sad to see the snow go. I went out and bought roller skis, and I smashed this arm, and I now have many pins and plates in this arm because I have osteoporosis. And I really smashed it, and my arm was literally the size of my thigh when I came out. But it's pretty good now. So yes, go live your life, and if you need surgery, then we tune your lymphedema up before you go into the OR, and you get what you need. If you have carpal tunnel syndrome, we treat your carpal tunnel syndrome. Lymphedema is not we never do anything. No, of course we do things, because people need things, and people break things. So no, that is... We tune you up, We get you the treatment you need, and we treat you post-op. Other questions? Oh, and I forgot to say, on the back, I put in a little thing on our Steps to Wellness program, and there's a Steps to Wellness table out there. It's free. It's a 12-week program, and we now have a program where people who don't live in the area can get help over the phone. So please go check out the Steps to Wellness table. And I'll stick around if anybody has any questions. Let me know. Thank you.